All right, so this is the week 3 for the pharmacology 2. Today we're going to be going over anesthetics in the musculoskeletal system. So the purpose of anesthetics, anesthesia is like Latin for without feeling. So generally they're used to treat pain, and they're very frequently used for sedation. Most people, when they think of anesthetics, anesthesia, they think of sedation. They can be oral, topical, inhaled, and they can be local or systemic. So there are some pre-anesthetics, and these are like what a person gets when they're anxious about a procedure, like an MRI or something along those lines, or visiting the dentist. And these medications are meant to help calm a person down and get them a little bit sedated before they start surgery. So there's a few different classes that go into this. There's the sedative hypnotics, which we've talked about a little bit in the last lecture set about the neurologically active drugs. And then there's the anti-anxiety, which we talked about a little bit too. And that includes benzodiazepines, which are very commonly used for these purposes. Then there's the analgesics, particularly the opioid type analgesics, which are the most effective analgesics. There's nothing that will eliminate pain like a narcotic. I mean, that's it basically. There's lots of drugs that have some kind of analgesic effect. But narcotics are the number one for treating it. And then there are anticholinergics, which they don't really treat pain. They don't really calm a person down, but they will kind of repair a person and can treat other side effects like the scopolamine patches for nausea, because a lot of the drugs used can have undesirable side effects like the nausea. So whenever a person is being anesthetized, there's 4 planes of anesthesia. And these are kind of, let's see, there we go. So, this is your baseline. This will be plane 1, plane 2, plane 3, plane 4. In theory, you never want to get plane 4. That's not the place to be. So in stage 1, you're first giving them the drug, and you're basically waiting for them to fall unconscious. So in this stage, you're giving like propofol or midazolam, something like that, and you're just kind of waiting until they go out. Then here, people will start to like lose feeling. They'll normally feel pretty good. They'll start to hallucinate a little bit, and then they usually start forgetting at this point. Stage 2, the person's been knocked out. And so I have excitement here and muscle activity and all these kind of things. And now my touch screen's there we go. So when I say something there, basically their body will kind of activate. They'll get a little bit of a fight or flight response, actually. And so their heart rate will go up, their blood pressure will go up, they'll start to breathe. They'll try to breathe more, but they're going to have a hard time doing it, which is where you get the irregular breathing. Their muscles will like twitch and contract. So that's stage 2. And then in stage 3, surgical anesthesia has been started. This is like the inhaled drugs, that kind of thing. And that lasts basically until the person is not able to breathe on their own. And they're not initiating breaths on their own. So there are substages of this that are graded based on respiration rate, pupil size, their muscular reflexes, and then their eye movements. Generally, for most surgical procedures, this is stage 3 is where you want to have the person, because their muscles are relaxed. They're not going to be moving around at all. Whenever the surgeon is making incisions, that kind of thing, they're not going to have the reflex twitching that could cause them problems. Additionally, there's stage 4, and stage 4 is not what you want to do during a surgery. This is where the person will have respiratory failure because This is where you actually inhibit the signals to breathe. Whenever you're at stage 3, you can have an impaired ability to breathe, but the person will still try to breathe, but their diaphragm is paralyzed. At stage 4, their nerve conduction is paralyzed and their diaphragm doesn't even get a signal. So that is very much not the goal, because if they stop trying to breathe, then you're also going to run into circulation problems, and it's going to go forward very quickly. There are some cases where you do want this. For example, if you're doing a heart transplant, heart transplants, you kind of kill the person for just a little bit because you stop their heart. So, there are times where you want to do this, but it's not very common. Additionally, in modern practice, stage 1 to stage 3 is a very fast transition, like extremely fast. Pretty much the anesthetists, they'll give the person their first push of, propofol or whatever they're going to give them. And then as soon as the person stops being responsive, they'll give them about another 10 seconds, and then they go straight on to intubation and the inhaled anesthetics. So inhaled anesthetics, there's few different classes, gases that are used, or volatile liquids, which is basically they're liquid at room temperature. They have a very high vapor pressure, and you can turn it into a gas very easily. This is like the anesthesia machines where you have the person sitting at their head and going. The way that this is generally used in practice is the anesthetist will give the person a mix of different gases, and they'll kind of switch between gases over time. That will help reduce side effects or toxicity from any of these. And the nitrous oxide should look familiar because it's used. It's the most common. You can modulate how much it's used. Like in dentistry, it's used at pretty low doses, and you're seeing essentially like the stage 1 sedation in dentistry. Where the person is kind of goofy and giggling, but then you can go deep with it. So then there's also about these inhaled anesthetics. They take effect very quickly. And what you'll actually see is that a person will perk up. So that's one of the stimulating side effects here. They're normally their heart rate will raise and that kind of thing. Now you're also giving the person, other drugs, like 30 others. It feels like anyway. So it's kind of a mixed bags. But if you're only doing the inhaled anesthetics, their heart rate and pressure and all that kind of thing will rise. These work in a somewhat similar, I use that loosely, somewhat similar way to benzodiazepines. They have a lot of shared effects. They have a little bit different action, but they have similar effects in the end, similar side effects as well. A lot of these anesthetics that are inhaled are not very well understood what their mechanisms are. Right now, kind of the common theory is that it disrupts the cell membranes, which then disrupts cell signaling, but it's a little bit up in the air still. But it is strong belief that if the person, it'll mess with the dopamine and serotonin signaling. So the person is on any drugs that modify that, it can interfere with the anesthetics, and they can often be brought too low. So injectable anesthetics, they're almost always used in conjunction with the inhaled anesthetics and vice versa. These have the inhaleds have better hypnotic sedative effects, whereas the injectables have better analgesia and muscle relaxation. Common ones are opioids, barbiturates, and benzodiazepines. So these are some examples. This is what you're going to be dealing with a lot more. In practice, you will very rarely deal with the inhaled medications. Generally, those are handled by the anesthesia department, and you don't really ever see them in the pharmacy. So etomidate is a pretty common one. This is a pretty potent muscle relaxant, and it'll knock the person out pretty quick. This is used a lot for rapid sequence intubation. Propofol is a super common one. This is the milk white solution. It'll knock a person out. They'll get loopy, and one of the big things is they will forget. It has a very strong amnesiatic effect. And of course, anytime it comes up, everyone makes a Michael Jackson joke. But this does work very well. I've heard it called the miracle water in the OR, and then milk of amnesia. Um, it's a good drug, basically, as long as you're not using too much and not using it too frequently. Thiopentyl sodium is used some. This is a barbiturate, and it's used some. The benzodiazepines are also used pretty often. These are very often used on initiation of sedation. So, like I said before, the diazepam, midazolam, a little bit lorazepam, but not as much, are used when inducing surgery. Lorazepam is used not for surgery as much, but for like the conscious sedation here, as well as the midazolam, and then they're pretty short acting. So, conscious sedation is a a technique where the person is awake. Oh man, I did a terrible job of writing that. So the person will be awake, but they're going to be really out of it. So a good analog to this, it's not the exact same thing, but a good analog is laughing gas at the dentist's office. But if you cranked it up higher, essentially. So let's try this again. There we go. Sedation. All right. So this is used a lot for biopsies. It's used for colonoscopies, that kind of thing. Where you just want to bring the person down. You don't really need them all the way knocked out. You just don't want them to be in pain. You don't want them to be moving around, that kind of thing. If someone ever talks about waking up during surgery and like the drugs didn't work or something, they didn't wake up from anesthesia. They woke up from conscious sedation. If a person wakes up from anesthesia, that is a big, big, big problem. Probably means that a vein got blown for the IV, and means that the anesthetist is doing a really bad job. So it doesn't happen. They definitely wouldn't remember it. So if someone ever says they wake up from anesthesia, they woke up from conscious sedation. Say that 3 times fast. So also used are the opioids, of course. So the most common is the fentanyl. This is a really good sedating agent. It doesn't last super long, but it might be used as a drip. And you can use it to like pretty well control the level of sedation, and then it also has analgesic effects. So it makes it's a really nice, useful drug for this kind of thing. Then the alfentanyl, remifentanil, and sufentanil, and it's on this list, but carfentanil, they're all basically a stronger version of fentanyl. They have slightly different properties. I see these they're stocked everywhere, but they're not used super often. They are used, but not very often. Mostly you'll see them used with opioid resistant patients. So like whenever someone is using a lot of opioids, then the fentanyl can actually be not enough to work on them. So then the other drug that's used is ketamine. So ketamine it's a neat little drug. So it has all these different effects, and you'll hear it, like horse tranquilizer, that's ketamine. And it's used very often for animals. And it is used in children a fair bit. With adults tend to have a really bad adverse event of having nightmares and like night terrors and frightful hallucinations when they have ketamine. Of course, it's not all the time, but it is very, very common. It's otherwise a really good drug, but if you give them too much, to actually do like long-term sedation. I shouldn't say long-term. If you use it more for than just like initiation or something like that, or breakthrough sedation, then the person's going to have some pretty rough side effects. So that's why it's not used very often. Now, side note, there is some active research with ketamine to treat like depression, actually, and some other things, but I'm not going to get into that right now. So, so that's systemic uh, anesthetics, is in terms of like anesthesia, hypnotics, that kind of thing. So, local anesthetics have a limited area of effect. They're used for a short procedure. They can be used for longer procedures, but generally for short duration things. Procedures anyway. And then there's different drugs. They can have different properties and then have different delivery routes. So some examples are, like benzocaine, procaine, tetracaine. These are all ester type local anesthetics. And then actually cocaine is in this class. Cocaine does actually have clinical use. It's stocked at many hospitals. It is very good for treating the ear, nose, and throat problems. It works very quickly. It is one of the times you see a lot. It's like stocked in the ER for this is for uncontrollable nosebleeds, because nothing works quite as well as cocaine for stopping a nosebleed, actually. So another interesting point, benzocaine here. So benzocaine is found in a number of different cough drops or like cough sprays. So that's not like, something that like, gets digested and absorbed that way. It is a topical throat lozenge. So that's kind of interesting. And then also for like sunburns, the Solarican, that kind of thing. So benzocaine works very well. And then amide type local anesthetics, which they're the ester types and the amides types. They're similar. There's a different chemical structure that changes essentially how they work, but they end up with very similar long-term effects. But the amides are much more common. There's more of them, and you can do more things with them. So bupivacaine is a very common drug used, Marcaine. Lidocaine is also extremely, extremely common. Bupivacaine is not used very often, but that's because it is about impossible to find where you can buy it, because it's on shortages perpetually. Prilocaine is another one that's not used super commonly. And then ropivacaine is used pretty frequently as well. Now, whenever I say like it's used commonly or not, I mean hospital practice. If you go to like an outpatient procedure kind of place, you're going to see different uses for things, and you'll see different drugs in different stocks. And then for other agents, you have the dicholine and the fluoxetine. The different types of local anesthetics. So there's topical, where you're treating either the skin or mucous membranes. Mucous membranes are really good at picking these up. So that's like your mouth, nose, throat, your ears, that kind of thing. You can also use them as nerve blocks, where you are interrupting and of course it's a nerve cluster, so it's not enormous, but it's a relatively large nerve cluster. So you can think about, if you're at the dentist and you get numbing medication, and like if you get the one down here, half of your tongue and like your cheek and your gum will all go numb at once. That is essentially a nerve block. You're hitting pretty far upstream before the nerve really differentiates out. So then you're getting a pretty large area effect. Now, the kind of converse to this is infiltration anesthetics, where you're going pretty close to wherever you're trying to deal with the pain. And this is like the most common, simplest option for numbing up an area of tissue. So this is like, if you think more Like whenever you get the top of set of teeth numbed, it doesn't really travel out the numbness feeling. It's mostly on the gum, a little bit in the lips, but not very much. So that's like an of an infiltration type of nerve block. And then there is spinal anesthesia, which is anesthesia in the spine. Um, and of course, this will affect anything basically lower than where you do the injection at. So you're gonna you can numb a person's like entire legs with this, or you can numb up like their stomach, or their whole abdomen. Um, and the spinal anesthesia, it is used like for sure, but what you're probably more familiar with is epidurals, which an epidural is basically a long-lasting spinal injection, because instead of just putting the needle in and giving your bolus and then stopping and pulling the needle out, you put in a catheter, and then you can keep giving the person medication. Excuse me. So one of the concerns with surgical anesthesia is malignant hyperthermia. And this is where it's due to a genetic mutation in ryanodine receptors, where the person will have overactive like heat production when their muscles contract. And whenever the person is undergoing undergoing their anesthesia, they can end up basically like continuously trying to contract their muscles, and then they can overheat themselves very quickly. So that is treated using the drug dantrolene, which will kind of break them out of that loop and stop the muscles contracting. And like this is a big deal when it happens. There are malignant hypothermia kits in just about every operating room. And then the other ways that it's treated, you cool the person down, you give them like 100% oxygen, you stop whatever you're doing on the surgery wise, and then they'll end up with really high potassium levels, but they're hyperalkemia. So hyperkalemia, sorry, hyperkalemia is very high potassium levels in the blood, and this can be very dangerous for a person. So then your kits that I mentioned just a minute ago, they will contain these drugs at the minimum. They can also contain other things, but they're always going to have this. All right, so moving on to the musculoskeletal system. There's different divisions, different types of muscle. So there's the skeleton, which is your bones and that kind of thing. You have your muscles, which do like the work. There's the skeletal muscle, smooth muscle, and cardiac muscle. So cardiac muscle, heart muscle is like its own little category. It has different ways that it works, different metabolic pathways that it will follow. And that's why your other muscles can get sore if you use them a lot, but your heart is constantly going, but it doesn't get sore. That's because it runs a little bit differently than the skeletal muscle. You have your smooth muscle, which you find in it's around your stomach, it's around your intestines, that kind of thing. Excuse me. Swear, I get on the camera and then I can't stop yawning. Skeletal muscles are for voluntary movement. So like as I'm talking to you, I'm using skeletal muscles. When I move my fingers, skeletal muscles. Skeletal muscles are also involved in reflexes. So it's not like 100% voluntary, but it's pretty close. And then there's the articular system, which is how bones interact with each other. So most muscular skeletal disorders are related to either trauma or aging. So there are contusions, which is basically any injury where the skin isn't broken. And an example of this is bruises. There's hematomas, which is where blood basically gets trapped. Blood flow cannot return back to the lungs and heart, and it'll kind of pull up. So like bruises, also, I mean, that's like a low grade example of it. Whenever you hear about somebody having like internal bleeding, that's a hematoma. And generally, if the hematoma is serious, it's because the person is losing blood out of their circulatory system more so than just like having blood accumulation, if that makes sense. And then, of course, there's lacerations, which is any kind of breaks or cuts in the skin. The two primary joint disorders are sprains and strains. So You know that a sprain is an injury to the ligaments of joints, and a strain is an injury to the muscle, either the muscle or the muscle tendon unit. So in a joint, this is not going to be the best drawing ever, but you have one bone here, along the top, and then you have, like your other bone that'll connect to. A ligament is the essentially kind of like rope like material that will hold the bones together, and while the muscle is what will do the pulling. So remember that a sprain is on the ligaments and a strain is on the muscles. Rheumatoid arthritis is a very common um, joint condition. It's very commonly associated with age and also with sorry. It's associated with age and then with repeated movements. So, like people who do a lot of knitting can end up with rheumatoid arthritis in their fingers. Another common example is drummers. Drummers can get rheumatoid arthritis. And normally that comes from the person using little muscles when they should be using big muscles. And using those little muscles, like they're using their finger joint instead of like their wrist joint to do, to clean up their technique or whatever, then that will injure the joints and injure the parts of the joints more than is, I guess, strictly necessary. Anyways, what it is inflammation of the synovial membranes of the joints. Synovial membranes, synovial fluid is the actual things that sit on top of the bone wherever they meet. Because if you just have the two hard surfaces rubbing against each other, they're going to wear each other down. It's going to be, just terrible. So synovial membranes are like a buffer, basically. You'll see degradation of the bone and cartilage. And normally rheumatoid arthritis starts slow and it'll get worse over time. So this is it can be a hard one to catch early because the person will often think just like, oh, I must have, just done it too much today or something like that. And then their joints don't stop hurting. Going along with this is osteoarthritis, which this is a different type of arthritis, but I have it on the same slide here. It is the most common in elderly, and it's due to bone degradation and reduced joint flexibility as a result of aging. It has a similar kind of end effect, but it's a different mechanism, it's a different reason. There's also gout. And gout is it's a joint inflammation. So arthritis and gout both have joint inflammation. The big difference with gout is that there are crystalline deposits, and these the crystals are uric acid crystals. So uric acid are the crystals in gout. And those crystals they'll deposit in your joints, and the bone or attached to the bone. They'll go into soft tissues like muscles and skin. They'll go into the cartilage in joints. And as they cause pain because there's little, basically crystals like little sand grains inside your joint, and those will rub and tear and damage tissue. So these also will cause nephropathy, which is like kidney pain, kidney injury, because you have little crystals going in, the kidney filters blood, but the kidney is not meant to deal with crystals in your blood. And then that can lead to renal impairment, and then also the kidney stones due to gout. Now, one thing that you do see with gout is it's normally localized to like a single joint. The big toe is a pretty common one. It doesn't really spread. It'll like form independently in multiple places at the same time, but it doesn't. It's not like, oh, you get it in one toe and then soon you have it in all the toes, unless you're doing something to cause the gout. That is, but so it's kind of an interesting thing that the environment that causes this to happen it's specific. It doesn't spread very much. So as far as drugs that block muscular activity, So these are neuromuscular blocking agents. And whenever someone gets these, they do not have any kind of muscle function. It's dose dependent, of course, but this will stop all kind of contractions, everything. A really common one is succinylcholine. That is a very fast-acting drug. This is a depolarizing muscle relaxant, which it can cause overheating in the patient. It can cause like over muscle exertion, because this will make their muscles just all go at once. And then they won't stop, and then the muscles will get like tired, and then they'll relax. And then the other ones are curium type drugs. It's not on here, but there's rocuronium, there's vecuronium, and then there's cisatracurium, and then the atracurium. So these are all fairly common. These are non-depolarizing, which means you can, have the person on this for, a fair amount of time. They can be either given as infusions or as boluses. You'll see them more often as boluses, and then you'll use different drugs to maintain the neuromuscular block in a surgery. But these are, you'll see them all the time for rapid sequence intubation kits and that kind of thing. So some more neuromuscular blocking agents. Still not on here, but the vecuronium, the turbocurane, pancuronium is used as well. And, so there's plenty of different subtypes of the curiums. So those are the neuromuscular blocking agents that give you zero kind of muscle activity. So I'm going to go back here. Zero muscle activity. Man, I spelled that super wrong. Zero activity, right? So then we have centrally acting skeletal muscle relaxants. So these are what you'll think of as muscle relaxants. They reduce muscle activity. Reduce, but not stop it. So a pretty common one is baclofen, and then cyclobenzaprine, flexeril. Those are probably the two most common. You'll see ribaxin as well. But whenever you think of like, muscle pain, those are the two drugs that you think of to treat it. Soma is also somewhat common. But basically what these drugs do is they will relax the muscles. They will not stop the muscles from working completely. What's a very common side effect of all of these is fatigue. So then we have the direct acting antispasmodic agents, which the spasmodic activity is like muscle twitching, basically. And so an antispasmodic stops that. It stops muscle contraction, or it stops muscle relaxation. Essentially, it'll one of the two. It'll lock the muscles either into fully contracted or fully released. And dantrolene is one of these. Remember when I talked about malignant hyperthermia earlier, and how dantrolene would treat it? That's because it stops muscle contraction. If muscles aren't contracting, then they're not making heat. Also on this list is botulinum toxin, which is Botox. And what these will do is they will lock the muscles into a contracted state, and that's how they pull out the wrinkles and that kind of thing. Now, Botox is extremely toxic. If it gets into your bloodstream, it is very bad. And it can kill you pretty easily if you have too much of it. So we also have quinine sulfate. There's several options. And then going into back to the arthritis drugs. So these are disease-modifying rheumatic drugs, anti-rheumatic drugs, which these will essentially, it says disease-modifying. They do alter how the body responds to these. The inflammation is due to an immune response because the immune system will detect damage. The immune system is not just for pathogens, it'll also detect damage to the body. So then you'll have inflammation as a, to try to increase blood flow and that kind of thing. So a lot of these are actually immune suppressants, and those will reduce the inflammation and then the pain. Methotrexate, you will see a lot as an example. It is not used very commonly in this role because it is quite toxic. Plaquenil, you'll see. Yeah. And in terms of that class of drugs for treating arthritis. Now, for biological type, so these are small chemicals. These are biologics, and you'll see these long-acting injectables a lot. Humira, Simponi, Remicade, Rituxan. Those are all very common, and these will sometimes be used with methotrexate. That's where you'll usually see methotrexate if you see methotrexate. These work on the immune system as well, but instead of just like suppressing it in general, it's a more selective modification of the immune system activity. So then for treating gout, there is colchicine. Colchicines, I've heard it said a lot of different ways. This is technically not FDA approved anymore. But it works well for treating gout, but it is no longer being it is no longer like indicated for gout, if that makes sense. It's an off-brand use. So it is an indirect anti-inflammatory. Unfortunately, the thing about it is it has a relatively high toxicity profile. If you remember from the drug development lesson, I mentioned how drugs sold before, I believe it was 1958, did not need any kind of FDA approval. Well, this was from that era. And then up until 2002, I want to say, the drug still didn't have to have FDA approval. And then after 2002, or whatever year it was, you'll have to forgive me. After that point, they needed approval. Colchicine was not going to pass that, so no one tried it. Then allopurinol is another big one that you see because it acts by eliminating the uric acid that's the main issue with gout. So I didn't go super in depth on those. There was a lot of them are used in the OR, particularly the neuromuscular ones and the anesthetics. So I mean, I kind of went through it pretty quickly. If you have any questions, please ask me. I put up that list of drugs from the PTCB that they think that you all should know for the sterile compounding certification. I do recommend you look through that. That is the whole list. I guarantee you're not going to need to know everything on there, but anything on there might come up on the test. I'll probably do a video at another date about essentially preparing for that. I'm going to pare down that into more relevant common drugs. So yeah, I'll be posting the quiz for this. If you have any questions, please ask me. And that'll be it for this week.